Hello, everybody. I'm Jordan Gipe. I'm a surgery resident at Mount Sinai Hospital in New York, and I'm really excited to be presenting our research on a pilot program to advance on advancing laparoscopic training in Namibia. Let me see if I can figure this clicker out. I have no disclosures. Seven seconds is a long time. All right. In this presentation, I will discuss the objectives of the Global Laparoscopic Advancement Program, or GLAP, and its implementation in Namibia. I will highlight the main takeaways from this pilot program, which include a regional needs assessment, as well as an evaluation of the use of simulation in surgical education in this region, and a look at how these surgeons acquired new laparoscopic skills during our program. So GLAP was founded in 2017 with the very purpose of educating surgeons in low and middle income countries on the use of safe laparoscopy and assisting in the development of sustainable educational programs in these regions. GLAP achieves this mission by establishing sites in LMICs, identifying local champions who then, with the assistance of GLAP faculty, aid in the replication of GLAP material and become a local simulation and education hub for that region's surgical community. GLAP has already demonstrated success in Mexico and Costa Rica and has attracted the participation from over 170 practicing surgeons and 260 residents in these countries, and now I'll be introducing their pilot expansion program to Africa. In 2022 and 2023, GLAP collaborated with COSEXA, the College of Surgeons of East, Central, and South Africa, to host a 3- and 5-day training program in Namibia. This course consisted of didactic lectures that were delivered by GLAP faculty. Needs assessment surveys were collected on the first and last day of the course, which were geared towards evaluating demographic information, evaluating the surgeon's individual experience with laparoscopy, and the resources that they had available to them in their training and at their home institutions. Each participant was also given an FLS task proficiency assessments, and data collected was analyzed using students' T and chi-squared tests. The primary objectives of our pilot program were threefold. First and foremost was to perform a needs assessment and evaluate the regional status of laparoscopic training and the perceived limitations and barriers to its utilization. Second was to evaluate the baseline proficiency of surgeons interested in or already performing laparoscopy in this region and evaluate their experience in laparoscopy. And then finally was to analyze the influence of GLAP on their laparoscopic skills within a simulated environment. So in total, we had 31 participants and 11 GLAP faculty members. From the needs assessment surveys, we found that our cohort has very limited experience with laparoscopy. As you can see in the pie chart on the right of the screen there, when asked about prior experience in laparoscopy, about 30% of our participants report little to no prior experience at all. Of those who had experience in laparoscopy, the vast majority learned laparoscopy through the observation of laparoscopic cases, with only 35% reporting any formal hands-on training in laparoscopy. We also found that participants' experience with simulation, as well as in objective feedback and assessments, were very limited. Nearly 90%, as you can see in this bar graph, reported no access to simulation equipment or a simulation lab. Additionally, less than 50% of our participants, as you can see in the bar graph on the right of the screen, less than 50% of our participants have ever practiced laparoscopy on a simulator in the past or used simulation to improve their skills. For these surgeons who work with trainees, 70% reported never using objective assessments to analyze their trainees' development. Thus, our study suggests that participants are learning by observation or teaching by observation, and yet do not have an objective or standardized method by which to adequately graduate their trainees or assess their training level. This may have significant implications for the safety of laparoscopic surgery performed in this region. When participants were surveyed about the most important factors limiting the use of laparoscopy, we found that lack of equipment, lack of trained surgeons as teachers, and lack of formal training in laparoscopy were the top 3 reasons reported. This portion of our study suggests that our cohort relies on surgical mentors and the availability of OR resources to learn laparoscopy, most often through observation. However, these are limited resources and are often considered the greatest barriers to entry for participants. Finally, participants were timed on their completion of the FLS task on the first and last day of the program and demonstrated statistically significant reduction in time to completion for the circle cut, peg transfer, and ligating loop skills. So in conclusion, we have a population with limited experience in laparoscopy and limited exposure to simulation who have learned laparoscopy almost purely through observation. Those with formal education in laparoscopy are sparse, and as such, trained mentors are a vastly limited resource, as is the lack of equipment, both of which are limiting the use and implementation of laparoscopy in Namibia. Increasing access to sim-based education can help with individual skill acquisition and improve the safety of laparoscopy in Namibia. Thank you. Happy to take any questions.